might be able to introduce Patti Harvey, who's a former Kaiser Permanente Senior Vice President in Quality Nursing and Clinical Operations. And I've long looked at Kaiser Permanente as one of the places where we can get inspiration in terms of driving a data-driven, population outcome-focused system approach. So I'm really looking forward to hearing Patti speaking about the importance of prioritizing population outcomes as we look to re-engineer and transform our system. So Patti, across to you.
Oh, thank you so much, Mike. I really appreciate the opportunity to be with you today. It is such a gift and blessing to hear our similarities between NHS and to hear our similarities with Kaiser Permanente, and then to hear the similarities and issues that face both of our governmental systems. As you know, in the United States, we're sort of in a transition phase right now. So it'd be interesting to come back and talk to me about this conversation in a couple of years, just so we can see how it has transformed. Again, a gift. I come to you this morning really engaged and committed to the topics that we're talking about. I loved listening to Kevin. I loved listening to Andrew. Professor Corbett touched on things you'll see within my conversation as well. So if you could go to the next slide, please, Carl, that would be wonderful. I wanted to start at the beginning. I come from Kaiser Permanente, worked there for almost 30 years. If I could continue to work and get my care at Kaiser Permanente, I would do it until the day I was no longer here. But for those of you that don't know the origins of Kaiser Permanente, I wanted to bring two slides to you this morning with some information. In 1933, Dr. Sidney Garfield was working in the fields in the Mojave Desert, trying to build dams. And I know that sounds really strange in the desert, but that's what he was trying to do. He and Henry Kaiser were close colleagues and really brilliant minds together. But Dr. Garfield was really concerned about workforce because you couldn't get people to come to the desert and work. So his whole mindset was, how do we keep our workers on the job? And how do we keep our workers happy? And how do we take care of not only our workers, but their families? Because we want to make this a system which looks at total health, not only for those who are working in our factories and on the dam, but also who are supporting them at home. And so with Dr. Garfield's brilliance, and you'll see on our next slide, Kaiser Permanente was formed. It was about prevention. It was about keeping folks on the job. It was about creating value. And it was about ensuring that we can separate the healthy from the well. If you take a notice of this article, and this is in public domain, and I would encourage you, if you haven't ever had the opportunity to see what the origins of Kaiser Permanente are, that you actually Google. The citation is at the bottom of the screen there. But where the premise of Kaiser Permanente and the way that we started was really quality medical care is a right that cannot be achieved unless we establish the need, separate the well from the sick, and do that without wasting our providers' time. And you heard much of that sentiment come through the previous two speakers. This was about being able to segment. This was about making sure we had care in the community. This was about being able to leverage and provide value to those we serve. And so Dr. Garfield wrote this article in 1970. And if we were to read this article out loud today, you would see that in his mind's eye and in his vision, he had predicted what the next 30 to 50 years might need to do to deliver on that separating the well from the sick and ensuring that we're adding value. So just a little history there before we get into the meat of the discussion about Kaiser Permanente and population health. But as you can see from Dr. Garfield and Henry Kaiser, that population health was on their minds at the very beginning. How do we keep our population of workers and their families healthy so that they can then deliver on that aqueduct, so that they can deliver on that producing health instead of just taking care of the sick. Next slide, Andrew. Or sorry, Carl. And this goes back to, and I loved what Professor Corbett said, because we're talking, first he talked about the triple aim, but we focus on the quadruple aim as well as the quintuple aim. But from a Kaiser Permanente perspective, we have put our triple aim, our quadruple aim, our quintuple aim into these sort of segments. And this is the way we begin to measure our success. First of all, it's care for the people. And the people doesn't necessarily mean just the people that are showing up in your hospital and your clinic. It means the people in which you're in the community in which we live and provide services. That is also the commitment to the environment. Kaiser Permanente is very strong in what we call value-based care. As you heard Professor Corbett talk about value creation, our premise from the beginning was, how do we provide value to those we serve, and how do we provide value to the communities in which we live? We have added patient experience, and I could change patient now into different words. I could add consumer experience. I could add the community experience, but really focusing on what matters to you and where you are. You heard a bit about segmentation. It's about taking the needs of the communities in which we serve patients or serve communities and ensuring that the needs that are available in our most poor, underserved communities are not what we would call paintbrushed to the needs of our more affluent communities. So really taking that opportunity to have that what matters to you and where you are at the forefront of our thinking. You heard from Dr. Garfield. Prevention and proactive care, avoiding the sick, preventing the sick is extremely important and organized to maintain health and foster healing. Next slide, please. And I'll go really fast. In order to do that, we have set forth national guidelines within Kaiser Permanente that take evidence-based guidelines, as well as what we have determined from our data. Next slide, please. An example, when we decide we want to change and spread and do things across our system, we put structure in it. And we not only look at what the problem is, what the customer or patient benefit is, but also what the financial output is and what's the benefit to our provider. And the last slide, please. Because I don't want to ever lose, I'm a nurse by training, ensuring what matters to not only the organization, but what matters to our members. This is my mom. This is my mom and I when I graduated from nursing school. And this is my mom in the third picture 3 weeks before her death. She, and the last part of her death, broke her hip and got a bowel obstruction. And we knew on this day that she said, Patti, I want to leave this hospital. I don't want to die here. I want to go and I want to have tomato soup and I want to be able to read my book and listen to my music. And that very evening that this picture was taken with my children, her grandchildren, we moved her to hospice care. And you heard much about hospice, the ability, I think you said a fifth of your beds are taken by hospice care. Can't stress end of life care enough. It's separating the well, as my mom saw herself, not as the sick. And with that, I will conclude and hope that there's a few questions that we might answer now and later.
Patti, thank you for that. As ever, it's always great to hear from colleagues from Kaiser Permanente, and that was really moving at the end as well. And I think it just shows the importance of how we make sure that we see our patients not as patients, but actually as people people within the context of their families, their communities, their neighborhoods. So thank you very, very much indeed.